perioperative patients having diabetes. We will take 1 or 2 questions.
So you don't recommend routinely transferring from a oral hypoglycemic to insulin prior to surgery? You can continue with the oral to short-acting sulfonylurea.
Yeah, if your patient is undergoing an elective surgery and the patient is stable glycemic control, and I don't see that the patient actually needs to switch. On the day of the surgery, he doesn't have his oral hypoglycemic agent, he's done by mouth. He has his surgery, and after that he can go home if it's on the same day or another day. It all depends on what surgery you're doing. If you're going to do a GI surgery for that matter, the patient is not going to be eating or is going to be in hospital for longer, I'm sure that's what you need. You need to give somebody insulin, he's going to be in hospital. If somebody's going to have, say, surgeries on the nose, surgeries on the eye, surgeries in the limb, they don't need to.
Even an abdominal surgery, suppose when the patient starts feeding on the second post-op day, do you need to convert? I'm a gynecologist basically, I do hysterectomy.
I'll tell you. What I have noticed is patients on extremely small doses of oral hypoglycemic agents actually can manage on the oral hypoglycemic agent on day 2. Okay? So you have to make that call, and that call comes from experience. If somebody is on a fairly large dose of oral hypoglycemic agent, I know the stresses of the surgery, and why are they on a large dose? Usually they have had diabetes for a longer duration. Then it is safer to be for them to be on insulin. But somebody on a very short history of diabetes, only 1 or 2 years, are taking only 1 milligram of glimepiride, I don't see any reason why you have to introduce insulin into this guy who has never taken insulin before. It basically involves patient's commitment to taking insulin. You'll be at war with your patients. So many of our patients refuse to take insulin. Okay, if it can be managed without it, they have to learn how to take the insulin, go home, so it is easier. At least in patients with small doses of OHS, it can be managed. And I've seen it every day. Okay, so it can be managed.
But all the sulfonylurea actually at present are long-acting. What you are told, glimepiride and others.
Yeah.
What short-acting we can?
The cheapest one in the market is the short-acting. The line is glipizide. Glipizide is extremely cheap, 55 cents or even less than that. So you would give them glimepiride, you may give them glipizide. You can even use glicazide. That's a reasonably short acting. So small dose of glicazide, 40 milligrams. That will be good.
After that landmark study of Allenbarn, which you have mentioned about 4 years ago, I think there, the mic is on. I think there have already been papers published refuting the idea of that kind of tight glycemic control, and papers are already out. And like perioperative beta blockade, which was in vogue quite some time, for a few decades, and now already papers are out for regarding the perioperative beta blockade. So I think that kind of strict glycemic control is very difficult to practice actually.
I think that you've answered the question by answering that same question. The struggle is where? The struggle is that we are not still that good at doing it. Just answer that. Okay? In real terms, is it possible to control people's blood sugar at a level of 110 or 120 for 24 hours a day without having hypoglycemia? No. That is where the limitation is. Would your patient with a blood sugar of 110 or 120 or blood sugar, if you manage to do that well without complications, have better outcomes? Maybe. Okay? The debate can continue. Alright? But the struggle is where, because our armamentarium today, or the skills that we have today, limits us from doing what we are doing. And you rightly said that. There's no doubt, most studies for elective surgeries, emergency, try and keep your blood sugars less than 200 or less than 180. That's your target. And for cardiothoracic surgeries, less than 140 is what now the ADA recommends. They haven't gone up to 110 because it is not possible to do it easily. That's the problem.
from here, in case you are not being able to take it as a first case in the morning, and the case is delayed beyond 11 a.m. or 12, and patient has to be on leave for oral because it's abdominal surgery, so the basal insulin etc. has to be given.
Yeah. What I normally do is, I think as you rightly said, I think the patient's already taking basal insulin, that's fine. But what you normally do, according to sliding scale, you give them a small, short-acting insulin. You do need to do that only for, say, patients with type 1 diabetes or basically patients who are actually insulin obedient, many years of diabetes. For a patient who's got type 2 diabetes, only a few years ago, are managing reasonably well with 1 or 2 milligrams or a small dose of OHAs. If they are fasting for that 6 hours, 10 hours, 12 hours, you actually sometimes don't need medication. Okay, so fasting is perhaps one of the treatments of treating diabetes. Though if you keep doing that, you will not live more than 4 years. That's a different thing. That trial also exists. But the fact is that so many of our patients every day seem to try and cut down on the intake. Okay, so there's another way of looking at it. But you can do that for a day or two. Jokingly, I tell some of my patients as well, because they complain. Yesterday they had ultrasound, they didn't have breakfast, and by the time it was done, they skipped their lunch as well. And today it is their surgery. Day after they had some other test or something like that. And so I have to jokingly tell my patient, so you belong to a state where if you do fast for a few days, you might just become cheap.
Thank you once again, sir. Thank you once again. So we invite our next speaker, nutrition in surgical patients, Dr. J.K. Malhotra.